can be epistaxis, they can be having hemoptysis or coughing out blood, they can be vomiting out blood or passing out blood in the stools or blackish stools. And they can also have bleeding on the skins, which can be quite obvious. Okay, so explore whether they have any bleeding tendencies that could be spontaneous. If they have spontaneous bleeding, we should think of whether do they have underlying thrombocytopenia or coagulopathy, or whether it could be drug-induced, such as antiplatelet or anticoagulations, and also whether the bleeding can also be due to traumatic or iatrogenic. Okay, and also if they have anemia, we should also think of, could it be hemolysis? In hemolysis, they tend to have jaundice, but sometimes the jaundice is very mild. The patient may not be aware of it. Okay, they can have dark or red color urine due to hemoglobinuria. And we should also explore whether they have other features of bone marrow failure. If they have anemia, do they also have thrombocytopenia, in which they can have manifestation with abnormal bleedings or recurrent bleedings, and they can also have features due to leukopenia, in which they can have recurrent infection or unusual infection, which does not happen in the immunocompetent person. We should also explore whether they could have any constitutional symptoms that contributes to anemia. So this can commonly due to underlying chronic illness, like, for example, chronic infection like tuberculosis or even a malignancy. Okay, and the features like symptoms like bone pain or pathological fractures will also alert us this could be underlying malignancy, possibly due to metastasis to the bone, or it could be primary malignancy in the marrow, for example, like multiple myeloma. Okay, that also can contribute to anemia. Okay. Symptoms of fever can also highlight the possibility of underlying infection and also malignancy, okay, as well as autoimmune disease. But in the patient who are very immunocompromised or severe neutropenia, the symptoms of fever can be absent. And we should also explore whether they could have any other symptoms related to iron deficiency. If you're thinking of possibility of iron deficiency anemia, they can have pica. They can have pica, whereby they would have abnormal eatings of things like, for example, sands or any other objects that are really usually not food. Okay, they can have a restless leg syndrome, hair loss or alopecia, poor concentration, and sometimes even glossitis. But glossitis is more common in relation to B12 or folate deficiency. In vitamin B12 deficiency, they can also have more often neurological presentation, such as fall or imbalance due to the demyelination of the corticospinal thalamic tract, okay? Or subacute combined degeneration of the cord. And they can also have a memory impairment. And one of the features you can ask in a patient whether they have glossitis is whether they have difficulty to eat spicy food. If in some person who likes spicy food, they will actually complain that they can no longer eat the spicy food because it causes more pain. Okay? So some of them, the anemic patient, they actually present this even much earlier before the anemia actually occurs. Okay, so we also need to explore any gastrointestinal symptom. How is the oral intake in general? Whether is it normal or it has been reduced gradually? If there is a gradual reduction in oral intake, then we should explore what could be the underlying cause. Commonly, is chronic illness or even some certain drugs or chemotherapy drugs that could actually affect your appetite. And in elderly, we should also bear in mind whether do they have any loss of dentitions. They lost their tooth until they have hardly any tooth and they do not use the denture. They could have difficulty in eating hard food like meat or even vegetables. So this could actually cause nutritional deficiency. Okay. Symptoms like dyspepsia, they could potentially highlight the underlying patient may have gastritis or peptic ulcer disease. In a patient with diarrhea, especially chronic diarrhea, they could lead to malabsorption, and this could be multiple causes, for example, inflammatory bowel disease, or it could be celiac disease, etc. So if it's acute diarrhea and patients presents with acute anemic symptoms, another differential if there is presence of hemolysis, you should think of as well is hemolytic uremic syndrome. Okay. Steatorrhea is also another symptoms that we can actually consider, especially they could highlight the underlying chronic inflammatory bowel syndrome or malabsorption. Okay. And if the patient, especially in elderly, they have altered bowel habit, we should think of underlying gastrointestinal malignancy. Okay. So in the patient who presented with anemia, we should also identify in them whether is this first episode or has there been previous recurrent episodes. And if they do have previous episodes, we should try to identify what could be the precipitating events or any underlying condition that precipitated, such as whether they have infection during that time, or was there any injection of certain drugs that precipitate the anemia. Okay. And we should explore if they have previous episodes of anemia, whether previous transfusion and in this previous transfusion, whether they are dependent on the transfusion. So this will actually highlight to us the severity of the anemia. And of course, because it will affect our management, we should explore whether they have any previous transfusion reaction, okay, which could lead to a potential hemolytic anemia. And we should also explore underlying medical history, chronic illness involving the liver disease, gastrointestinal disease, renal disease. All these could lead to anemia of chronic illness. In rheumatological disorder, it could also lead to anemia of chronic illness, but they are also multifactorial, in which the use of certain drugs like immunosuppressants or even the NSAIDs or painkillers also contributes to the anemia indirectly by causing peptic ulcer disease. Okay. In cardiac disease, also we should consider, especially when they have a prostatic or a valvular heart disease, they are susceptible to hemolysis, and the use of anticoagulant or antiplatelet also can contribute to the risk of bleeding and anemia in a patient with heart disease. In a patient with hematological disorder, underlying hematological disorder, they could also have anemia. For example, in a patient with a coagulopathy, such as hemophilia or immune thrombocytopenia, they could have occult or overt bleeding that contributes to the anemia, commonly iron deficiency. And if you have underlying anemia, marrow disorder, for example, aplastic anemia, myelodysplastic syndrome, or or even chronic myeloid leukemia, the anemia could also progress and worsen. And that could highlight a transformation to something more acute. Infections, particularly chronic infections, commonly can contribute to anemia of chronic illness. Acute infections like malaria, similarly, can cause anemia, acute anemia in particular, due to hemolysis. Okay, so malignancy can contribute to anemia as well, in particular anemia of chronic disease, but in malignancy involving the mucosal tract, for example, gastrointestinal, urinary, or genitourinary cancer, they could also contribute to iron deficiency. And treatment of the underlying malignancy, the bone marrow also contribute, as well as cytopenia. Another important history to explore is also surgical history. So we should also explore whether they have recent major surgery, because this can contribute to blood loss. Okay. And in a patient who has bariatric surgery resulting in shorter bowels, or they have a gastric bypass, this can contribute to nutritional anemia, as they are no longer being able to absorb the nutrients in a normal way. Okay. Family history is also important, especially if the anemia occurs in the young, or the anemia is chronic and recurrent, precipitated by certain conditions like infections or certain drugs. Okay, so but in particular, thalassemia or sickle cell disorder, these are very common hereditary cause of anemia. In the membrane, red blood cell membrane defects such as hereditary spherocytosis, they could also have a chronic hemolytic anemia, or at times when they are precipitated by stress. Enzymopathies, in particular G6PD deficiency, is very, very common, especially in our region here. In Malaysia, we do encounter G6PD, and we have a routine screening at birth to make sure we diagnose them early and follow up them. Okay, so drug history is also important. We do ask history, that especially when we are considering the patient have event of bleeding or iron deficiency anemia. Okay, so we need to explore the use of NSAIDs or aspirins, antiplatelets, as well as anticoagulants, and factors, certain drugs that could precipitate the hemolysis, and there are a whole list of drugs, especially in G6PD, and certain drugs, they do induce immune hemolytic anemia. And toxins due to chemo or radiotherapy, they can actually cause bone marrow suppression. Diet history is also another important aspect to be explored. We should explore whether they are vegetarians or vegans. The vegans usually tends to have more severe anemia. They tend to have B12 or folate deficiency, same as those who are alcoholic, having a heavy alcohol drinking or abuse, chronic alcohol abuse. Okay, and if they are anorexia, or they should also be considered as a cause of nutritional anemia, in particular iron, folate, and B12. So history of travel, especially to certain places, are endemic with malaria. So if they're having fever, symptoms of fever, we should consider the malaria as causing the severe anemia, especially hemolytic anemia. And if they have been exposed to helminths, eating raw meat sometimes, they could actually potentially cause anemia as well, especially iron deficiency. Okay. So what do we examine for in a patient who actually come to us with anemia? Okay. So in general, we should actually look at whether are they well or are they unwell. Okay. If they are well, usually the condition is underlying chronic problem, okay, chronic anemia. If they are very unwell, we should think that it could be either very severe anemia, or it could be very acute anemia. Okay. So when we see pallor, we should also look for jaundice, okay, whether it's present or not, by looking at the conjunctiva and sclera. Okay. And presence of abnormal faces, particularly prominent maxillary prominence, okay, that could actually suggest underlying thalassemia, especially thalassemia major. In a well transfused thalassemia major, however, you may not be seeing these abnormal faces. So if the patient have cachexia, okay, they could also reflect the patient may have underlying chronic malignancy, or even chronic infections like tuberculosis, or it could be also due to anorexia nervosa. So we also need to assess in general the hemodynamic status, particularly the blood pressure, to look for hypotension or tachycardia, tachypnea, and fever that could reflect infections, malignancy, or autoimmune disorders, or even hypoxia from the pulse oximeter. And going to from the general overall examination, then we proceed to specific examination. So we actually look into the oral to look for the dentition, whether they have loss of all their teeth that could affect their oral intake. We also look for any glossitis, as shown here in the pictures, or angular stomatitis. Okay, these are usually common in iron deficiency, in particular glossitis, and also in B12 deficiency. Sometimes it could be worse than this. It could be just very smooth. Okay? And nails and skin examination will give us some clues, especially if you see a spoon-shaped nails called koilonychia, they could reflect underlying iron deficiency. If you see bruises or petechia, that could reflect, they could have a bleeding disorder either due to coagulopathy, underlying thrombocytopenia. And if you see vitiligo, in which you can see the peripherals, they are white, white color. So on the skins, they could be associated with autoimmune disorder, which can contribute to conditions like pernicious anemia, in which your vitamin B12 level can be deficient. So we should also explore whether they examine whether they have any lymphadenopathy. This lymphadenopathy can be due to underlying lymphoproliferative disease, or it could be secondary metastasis due to underlying malignancy, or even infections, particularly like tuberculosis. So abdominal examination is also important. You should see whether they have any surgical scars that could reflect underlying previous major surgery, in particular like gastric bypass or even colectomies, and as well as any abdominal mass. If we see any abdominal mass, could be whether they are colonic mass, or in a female, whether they are fibroid mass. Okay? And splenomegaly as well, it could reflect the patient may have hemolysis, okay, chronic hemolysis in particular. Acute hemolysis, they do not cause splenomegaly, but it usually occur in someone with a chronic hemolysis. Okay? And per rectal examinations is indicated if the patients complain having a blackish stools, or we would like to reconfirm to see whether there's presence of melena, and you could also see whether there's presence of hemorrhoids as well. Other relevant systemic physical examinations, we should also explore the lungs for any effusion. Sometimes they could have hemothorax or any abnormal findings that could contribute to chronic disease. Okay? In TB, sometimes the examination may be normal, but you may find them on the chest X-rays. Okay? Cardiac examinations, you should listen for murmurs. Okay? And in neurological examination, sometimes you may find signs of peripheral neuropathies or loss of proprioceptions, sensory ataxia, or subacute combined cord degeneration. Okay? So here there may be areflexic with peripheral weakness. We should also see whether they have any features clinically to suggest renal failure. They could be having sallow appearance, or they could be in liver failure. They could be having other stigmata of chronic liver disease. Okay. Okay. So after physical history and physical examination, we would normally screen with a basic laboratory test if we suspect anemia. So what we do normally is we do a full blood count with differentials looking at the white blood cells. Okay, so we also look in particular, we focus on the hemoglobin level, and we look at the mean cell volume of the red cells, the white blood cell count, as well as the platelet count. because we would like to know whether is it isolated anemia involving just the red cell lines, or is it involving two cell lines such as anemia with thrombocytopenia, or is it three cell line or pancytopenia, okay, whereby all the cell line, the red cell, white cell, and platelet are low. So this would be useful clue whether the disease could be involving the bone marrow or not. Okay, sometimes we do reticulocyte counts, but it's not compulsory, it's not necessary. It's not something that is routinely done, but it could be helpful to reflect whether the bone marrow is reactive or functioning. In the marrow disease, we normally, if there is low production of red cell from the bone marrow, the reticulocyte count will be low. Or if they have a bone marrow suppression or any bone marrow disorder, the reticulocyte count will be low. Okay, so sometimes we do peripheral blood films, so it can be sometimes useful, especially when we are looking for any abnormalities in the red cell morphology, and also if there's presence of abnormal cells reported on the full blood count counter. And even any cytopenia, we would like to see whether are they, especially thrombocytopenia, are they truly thrombocytopenic or not. So the peripheral blood count would be very useful. So another test, if the patient is jaundice, okay, so we would do a hemolytic workup as well to look for any presence of indirect hyperbilirubinemia. There can also other hemolytic markers such as lactate dehydrogenase, LDH, or heptoglobin. So LDH usually increase in hemolysis, okay? And heptoglobin will also be reduced in hemolysis. And when there are features of hemolysis presence, we do want to identify whether are they immune or non-immune hemolysis, and here we do the direct Coombs test to determine. Okay. In our Malaysian setting, we don't routinely do the urine test to look for any hemoglobinuria. Because the blood test is actually quite sufficient for us to identify whether they have hemolytic anemia. Unless the patients, if the patient presented with hematuria or red color urine, and the clinicians wants to be able to identify whether it's truly hematuria or hemoglobinuria, they will also do a urinalysis first, and sometimes if really required, then only they will do a urine for hemoglobin. Other further evaluations would depend on the mean cell volume, as well as the PBF findings, the peripheral blood findings. So in the patients with who has a microcytic anemia in general, we would of iron deficiency, hemoglobinopathies, in particular thalassemia. Sometimes they could have both iron deficiency anemia with underlying thalassemia. So we would normally screen for iron first before proceeding to the diagnosis screening for thalassemia. Okay. In a patient who are normocytic anemia, in which the MCV is normal, so we will actually look at the reticulocyte counts to see whether is the bone marrow in general suppressed, and also sometimes we may consider bone marrow biopsy if there is no other explainable non-hematological disorder or chronic disease. Okay. And in the patient with macrocytic anemia, we would consider checking the serum for folate and B12 because these are the commonest cause of anemia. But if the folate or B12 level are normal, then we would consider bone marrow examination, because other causes of macrocytic anemia that we should consider is presence of underlying myelodysplastic syndrome. Okay. So this is just a very complicated, but just summarize of how we approach. Okay. So here, when we detect the anemia, we evaluate the mean cell volume and to see other red flags on the red blood cell report. So if they are abnormal, then we would proceed with peripheral blood smear if there's abnormal red cells seen or reported on the counter. But based on the mean cell volume, if it's low, which is hypochromic, so the first thing would be iron study. So the interpretation of iron study would be useful to help us to differentiate iron deficiency anemia from anemia of chronic disease. Okay. Here in iron deficiency anemia, in iron study, we usually do the serum iron. However, we have to be cautious when doing serum iron. We should do it during fasting, because if we do not fast, the iron level could be normal, inappropriately normal in a patient, even if the patient has iron deficiency, if they have just taken some iron-rich food or even the supplements. So another test that we commonly do is total iron binding capacity, and also a ferritin. So ferritin is actually the preferred test, because that would reflect the iron store. So in a patient with iron deficiency, they have high total iron binding capacity and low ferritin. Okay? And to differentiate this with anemia of chronic disease, such as those with chronic infection or inflammation or autoimmune disease or malignancy, their ferritins are normally normal or high, okay? Because ferritin is an acute phase reactant. So in these conditions, in anemia of chronic disease, their iron level is low, but they have normal or high ferritin. If the iron is high, but the patients have hypochromic anemia, this condition can be due to iron overload, which is common in a chronically transfused thalassemia patient, or least commonly sideroblastic anemia. Okay. In the normocytic anemia, chronic normocytic anemia, it can be due to patients with anemia of chronic disease, most commonly due to underlying chronic renal insufficiency. However, any other chronic infections or malignancy can also be normocytic initially. In the acute blood loss, here the presence of acute hemolysis or acute blood loss, because of the increase in the reticulocytes in the peripheral blood, so the MCV can actually be normal, even in the presence of hemolysis. Okay? And so in the patient with bone marrow suppressions, with the low reticulocyte counts, the productions of, especially if they are not dysplastic, the red cell can still be normocytic in size. Right? In iron deficiency anemia with mixture of folate or B12 deficiency, you can have an anemia with a normal MCV as well. So because if you have an isolated folate or B12 deficiency, you have an increase in MCV, commonly about 110 or 120. Okay? So the most common, if you see in high MCV, we should consider folate or B12 deficiency. Usually in our setting here in Malaysia, we just do the fasting serum B12 and folate, because the B12 and folate level also will be affected by meals. Okay, so they need to be done in fasting. So unless the patients has borderline B12 and folate deficiency, and we still suspect the deficiency present, then only we can do this test, methylmalonate or homocysteine. However, these tests are not routinely done, and they are not available in many places. Okay. And rarely in the patient with anemia, chronic anemia, if they have increase in the MCV due to underlying myelodysplastic disorder. Here, you can have dysplastic features presence in the peripheral blood film. And you can also have cytopenias in other cell lines involving the red cell as well as white cell and platelets. Okay. In other conditions, particularly liver disease, hypothyroid, and certain drugs, they can also cause an increased MCV. So we will need to explore from history whether they do have other disorders or drugs contributing this raised MCV. In fact, sometimes, especially drugs, they may not necessarily cause anemia, but they just have increased MCV. And it is sometimes a useful parameter to know whether they are compliant to the drugs. For example, like hydroxyurea or certain drugs like antiretrovirals, the presence of increased MCV in a stable hemoglobin level, it will reflect that they are actually compliant to those drugs. Okay. And if in the patient with increased reticulocytes due to hemolysis in particular, they can have increased MCV. So based on here, in fact, in a general primary care setting, sometimes tests are very limited. We only have full blood count setting. So in this kind of situation, when they do suspect iron deficiency from the history of physical examination, sometimes the clinicians do consider trial of oral iron therapy just to diagnose iron deficiency. And this trial usually about 2 weeks just to see whether there is any clinical response and response in the hemoglobin. If there is some improvement, then they could also diagnose iron deficiency anemia. And when certain conditions where you have iron deficiency anemia overlapping with anemia or chronic disease or any other disorder, they do give trial of oral iron therapy to see whether there's improvement, especially when you have very limited test results available. Okay, and if there's no response, then and you may consider either to stop and to try to look for other causes. However, if they are truly iron deficient, then we should explore what are the causes they are not responding to the iron therapy. Okay. So basically, I'm going to focus more on the iron deficiency anemia. So that's why I put up these slides to help us to interpret the iron studies. So as mentioned, the serum iron level has to be done in a fasting state because it's affected by any iron intake from food. And sometimes hemolysis can also affect the serum iron level. And in a patient with low iron level, we cannot exclude anemia of chronic disease. Okay? Serum ferritin is the most sensitive and most specific test for iron study. And however, we need to bear in mind that this is an acute phase reactant which can increase in other chronic conditions. Okay? For example, chronic disease, inflammations, or malignancies. And they can also be physiologically increased in pregnancy as well as age. So to diagnose iron deficiency anemia, if the level is less than 30 nanogram per mil, would reflect there is iron deficiency. But in the patient with a chronic disease, because of the expected higher level of ferritin, the cutoff level in this patient will be higher. They would have a level of 100 or below 100 to diagnose chronic anemia of chronic disease in such chronic kidney disease patient. And the cutoff is even higher if the patient with renal failure who are on dialysis. Transferrin saturation is also another test that we do. Sometimes the test would be run automatically. But if they do not produce these results, we can actually calculate if we have the iron level and the total iron binding capacity level. And we can manually calculate the percentage of the transferrin saturation. And the cutoff to diagnose iron deficiency anemia is when the cutoff is below 16%. And if the patient have chronic disease or any inflammation, the cutoff is higher. When the level is 30% or below, then we should consider having iron deficiency. Okay. Bone marrow test is actually a gold standard, but despite it's a gold standard, it is not a routine recommendation, okay? Because the bone marrow is a storage, iron storage. So we don't do it routinely because it is a very invasive procedure, but we can diagnose iron deficiency sometimes simultaneously when we are actually looking for underlying hematological disorder, when we see the ions stored in the white cell are reduced in the bone marrow biopsy. Okay. Okay. So this just a table just to show you that iron deficiency states it can be iron deficient without anemia. You can have functional iron deficiency, which is also without anemia, or you can have other states of iron deficiency with anemia. Okay, in iron deficiency without anemia, everything is normal. It's just that the serum iron and the ferritin are low. Okay, but they are not anemic. It is not severe enough to cause anemia. Okay. And in functional iron deficiency, this is actually a subset of anemia of chronic disease. Okay, here because of the functional iron deficiency, you do notice the iron can be low, but sometimes they are also normal. But what differentiates it with iron deficiency without anemia is that the ferritin are normal, okay? Because as like commonly happen in any chronic disease, the ferritin can be normal or even high. So in iron deficiency with anemia, so you can have pure true iron deficiency anemia, in which you have low iron, low ferritin, and transferrin saturation, and you sometimes may need to differentiate from the true anemia due to iron refractory iron deficiency anemia, or anemia of chronic disease, or they can have overlap of iron deficiency anemia with anemia of chronic disease. Okay, in this anemia of chronic disease and anemia or overlap anemia of iron deficiency anemia with anemia of chronic disease, the ferritin level would normally be on the higher range. Okay, they are not as low as in true isolated iron deficiency anemia. Okay, and in iron refractory iron deficiency anemia, in this condition, this is very, very uncommon, and it's an inherited genetic mutation. The iron storage is actually, the iron is there, but they do not they're actually low because they cannot utilize the iron. Okay, and it's very, very, very uncommon. And usually they are refractory to oral iron therapy, and sometimes even they could be lifelong dependent on the IV iron. Here, soluble transferrin receptor and hepcidin, all these reticulocyte, hemoglobin content, these are other tests that could be done, but it's only done under research setting, and we don't actually do it routinely in our clinical setting. Okay, and this just to summarize, this table just to summarize the anemia in terms of red cell volume. So if you see any reticulopenia, it indicates that there is a marrow suppression. Okay, if there is a reactive marrow, the reticulocyte will be increased. So these are the conditions that are associated with marrow suppression, and here are the conditions associated with very reactive marrow to compensate for the anemia. And I'm going to detail. Okay, so when do we actually do bone marrow? We do bone marrow if we suspect the anemia is due to underlying bone marrow disorder, in particular when there is pancytopenia, which is not attributed to underlying autoimmune disease. Okay, if the patient has autoimmune disease, or the patient has been exposed to certain drugs, in particular chemotherapy or radiotherapy, or if they have hypersplenism, we don't routinely do pancytopenia. So only when we have excluded other causes, pancytopenia of other causes, then we do bone marrow. Or if we find there's any abnormal cells on the red full blood count counter or on the peripheral blood film, in particular any blast, we would also do a bone marrow to diagnose the underlying leukemia or conditions like aplastic anemia, myelofibrosis, or myelodysplastic syndrome. And in patients, sometimes with underlying malignancy, they may have cytopenia, in particular pancytopenia, and at times they may be uncertain whether the cytopenia could be attributed by the chemo or bone marrow infiltration. Here, the bone marrow biopsy will be helpful. Okay, so imaging studies is also considered if we suspect patients having anemia with bleeding. So in the patient with gastrointestinal bleeding, which can be occult or overt bleeding, we do esophageal gastroduodenoscopy or colonoscopy if indicated. And sometimes if there's no obvious source, we do capsule endoscopy as well. Okay, but of course, prior to this, if in bleeding, where we suspect bleeding, routinely we would do a stool occult blood, or if we suspect chronic parasite infections, we would do stool for ova and cyst as well. If the patients have urinary symptoms and we suspect the patient may have chronic blood loss from the urinalysis, we would also do a cystourethropy or even a cystoscopy. Okay, so usually here we would refer to the appropriate discipline to do the further investigation. And if in the female patient, if they have gynecological bleeding, so we would advise them for pelvic ultrasound. Other relevant investigation in a patient with anemia, if we found any abnormality or chronic stigmata or liver disease, we should also do ultrasound to look for any hypersplenism, any presence of underlying liver disease or renal disease. Okay? Especially in renal disease, they may have a shrunken kidney size that could reflect as well, especially when they have a high creatinine level. So if the patient have constitutional symptoms or any mass, abnormal mass that we are thinking of a malignancy, we should also consider CT scan or PET scan to look at the malignancy. Okay, so in general, how do we treat anemia? So the treatment would actually depend on the underlying cause of anemia. As we have gone through, anemia can be due to so many different causes. So the treatment would be depending on the cause. If there is any nutritional deficiency, we should replace them accordingly. Okay? And we give supportive transfusion only in circumstances whereby the anemia is very severe, compromising the end organ function. Example, they can have angina or heart failure, but do be careful in the patient with presenting with cardiac failure, because transfusion can precipitate the overload, fluid overload. So we should make sure they are well diuresis before we give them the blood transfusion as well. In the patient with iron deficiency anemia, we try not to transfuse them if possible, but sometimes if they are complicated with serious or very acute ongoing bleeding, in which the replacement, oral replacement or intravenous replacement would be not sufficient to catch up with the blood loss, then we may have to transfuse them. Okay, and in patients with severe anemia, if they do have underlying bone marrow pathology, which it will not respond to erythropoietin hormone stimulation, we have to transfuse them accordingly. So there may be sometimes role of erythropoietin hormones, but mainly in certain disorder, in particular chronic disease, chronic kidney disease, or hematological anemia. Okay, due to underlying like condition like myelodysplastic syndrome or chemotherapy. Okay. All right. So now I'm going to focus more on iron deficiency anemia and its treatment, as this is the most common cause of anemia. So iron deficiency, as I mentioned earlier, can occur with or without anemia. And why iron deficiency anemia occur? So there can be imbalance between the availability of the iron, or there can be also increase in the iron need. Okay, so the decrease in the iron availability can be because of the lack of intake or absorption. Okay, whereby could be due to dietary restriction. There can be use of antacids or proton pump inhibitor, which actually inhibits the absorptions of iron. So chronic condition like celiac disease will also affect the absorptions of iron, okay, in the gut. Same goes for gastric bypass, okay, or gut, or even a gut resection. Okay, so here, because of all the mucosal defects in this intestine, so we would actually expect the absorption to be impaired. H. pylori infections can also contribute to iron deficiency anemia because they cause chronic gastritis, and treatment of line H. pylori infection actually can reverse the chronic iron deficiency anemia. High caffeine intake, as well as like coffee or tea, and also calcium supplements can also impair the calcium, can also impair the iron absorption from the diet. So, or even the iron supplements that we give orally. So that is why it is advisable for the patients with iron who are taking the oral supplements to avoid taking caffeine or calcium supplements along with the iron supplements. Okay. So in chronic inflammatory disease, chronic kidney disease, heart failure, they can also have a decrease in the iron availability due to the sequestration of these ions in the macrophage. So in this chronic condition, even in obesity and refractory iron deficiency anemia, this sequestration is actually occur due to high hepcidin, which is a protein produced from the liver. So with a high hepcidin level, it actually inhibits the iron release into the circulation. And another cause of iron deficiency is when there is an increase in the iron need. Okay, when your iron need is greater than what is available, Okay, so that can happen especially in pregnancy, because we have increased needs for iron during pregnancy, and as well as childhood for growth. In extreme exercise, you can have increased iron needs as well, because they can be requiring more muscles. More iron is required for the muscles as well. So when there is also excess of blood loss, okay, we would need more iron, okay? But if the blood loss is excessive, that would cause more, that would cause an iron deficiency anemia. So this commonly can be genitourinary blood loss, gastrointestinal, as well as iatrogenic. Blood donation, they do cause iron deficiency, but they should not cause iron deficiency anemia. We do not accept patients who are anemic to donate blood. Okay, and a patient with severe epistaxis, they can also have iron deficiency. And if it's chronic epistaxis and recurrent, they could cause iron deficiency anemia as well. So the treatment of iron deficiency anemia, we cannot rely on iron-rich diet alone. Okay, because the maximal absorption from our gastrointestinal of the iron is about 1 to 2 milligram per day. But even in a healthy adult, we also lost iron in about 1 to 2 milligram per day. So that is why in a patient with iron deficiency anemia, we cannot rely on the iron diet, okay, due to the diet absorption capacity is very limited. Okay, so that is why in iron deficiency anemia, we should try to supplement it. The first line would be oral iron therapy. Okay, the maximal intestinal absorption of the oral iron would be about 25 to 50 milligram per day. So any higher dose, they may cause more side effect of the iron. Okay, in particular gastrointestinal side effect, which are dose dependent. Iron therapy, parenteral iron therapy is also another mode of iron treatment replacement. Okay? And of course, blood transfusion is the last option when there is cardiovascular compromise or hemodynamic instability. But even with blood transfusion, we also need to supplement with iron therapy, because when we transfuse, we do not transfuse to normalize the hemoglobin, but to make it sufficient above 8, hemoglobin of 8 would be suffice. So subsequently, to normalize the iron store, we would replace with iron therapy. Okay, because blood transfusion is not without risk. Okay. All right, so when do we use IV intravenous iron therapy? So iron therapy we should use when they could not tolerate oral iron therapy. And or if they have been on optimal iron therapy and they do not respond, so we should consider the use of iron therapy. In the patient where, especially a surgical case pre-operatively, we do not want to transfuse them, but we want to rapidly increase the iron stores, especially if the surgery is in about 1 month or 6 weeks time. So we can use the IV iron therapy to increase the iron stores to avoid transfusion. Okay, or in certain conditions whereby the patient refuses blood transfusion due to religious issue like Jehovah's Witness. Okay, so iron therapy in combination with EPO may be considered in this group of people. So side effect of iron therapy, as mentioned, they're mainly gastrointestinal, commonly nausea, vomiting, abdominal pain, constipation, and sometimes also diarrhea. Okay, so if they have gastrointestinal intolerance, in particular nausea, vomiting, we try to advise them to take on alternate days to help to relieve the symptoms. And also we advise them to take either with empty stomach or just with meal. So the constipation is also another common problem in patients on oral iron therapy. So they actually can be a main factor to cause them to be non-compliant as well. And how we advise them would be increased fluid intake or increase in the fiber intakes like vegetables or oats. Okay, and also sometimes if this does not help, we can actually advise them to take a stool laxative or stool softeners to ease the symptoms of constipation. And to optimize the oral iron intake, we advise them to take with vitamin C. Some of the iron supplements, they do come in combinations with vitamin C, but if they don't, they can take along with fruit juice or vitamin C supplements. Okay. And they should avoid drugs or certain foods, as mentioned earlier, that can affect their absorption. Okay. So IV iron, on the other hand, is a second line because sometimes there are risks associated with the use of IV iron. They are uncommon, but they can occur, and in particular, hypersensitivity like rashes or urticaria, and usually we cover them with a short course of steroids or antihistamines during the IV iron infusion. And in more severe cases, but very, very rare, they can develop an anaphylactic reaction due to iron therapy. And these are more common with the use of iron dextran compared to the other groups. Okay. In IV iron, we should avoid the use if the patient is having concurrent infection because the IV iron will release the iron directly into the bloodstreams. And iron is a nutrition source for bacteria, and so it can worsen the infections, in particular bacteremia. And some more when the patient is having sepsis, they are already having stress, and iron can be very toxic because it's can contribute to the oxidative stress as well. So we should avoid use of IV iron during the infection. Okay. All right. So this is just to show you some of the different forms of iron salts available. In Malaysia, what we commonly have is ferrous fumarate, and in in our government hospital, usually we have ferrous fumarate in a pure form. But sometimes when the patients could not tolerate, we do advise them to purchase the iron supplements in private, whereby they could have combinations of vitamins and in other forms such as ferrous gluconate. So we don't have other forms like ferrous sulfate or ferrous available in Malaysia. So basically, you can see that most of these iron, they are actually available in the ferrous form. The ferrous form is ferrous 2+, okay, and they are available as such because they are better absorbed compared to the ferric form, okay, or the ferric preparation. But the ferrous form has more gastrointestinal effect, as mentioned earlier, okay. There are ferric forms available. For example, some of the brands like Maltopher. However, their absorption, they are more tolerable in terms of gastrointestinal, but their absorption may not be as great. Okay. So what do we expect when the patient is taking iron therapy, oral iron therapy? So as long as they do not have any ongoing blood loss, we do expect some increment in the hemoglobin, but it's very little. It's just about half to 1 gram per week. So if you want to correct an anemia with a hemoglobin level of 8, you may expect a few months to increase that. But if you really need to increase the hemoglobin rapidly, the use of IV iron would be much faster, okay, to rapidly increase the iron store. So as long as the iron loss is, blood loss is absent, we can monitor the patients in about 4 weeks' time to see the response. But if there is acute or ongoing loss, the hemoglobin response, we would not be able to wait for 4 weeks. We need to monitor them much earlier. Okay, as we may need to correct them more aggressively if needed, and iron supplements will not be sufficient, especially oral. In the patient, once they have, in the patient with iron deficiency anemia, so once they have normalized their hemoglobin, we would actually continue the oral iron therapy for about at least 3 months and sometimes up to 6 months to make sure that their iron stores is replenished, okay? And here, when they're replenished here, we can actually know when their ferritin level has normalized. Okay, this is in the patient without anemia of chronic disease or overlapping, because if they have coexisting anemia of chronic disease, the iron level, the ferritin level will be expected to be higher. Okay. All right. So in a patient with inadequate iron response, we should actually explore the cause. Then one of the main cause of inadequate iron response is when they have non-compliance to the therapy. And these are actually quite common due to the side effect of the oral iron, as mentioned. And sometimes when they do not take the dosing adequately, that could also contribute to the lack of response to the oral iron. Other causes that could contribute is when they actually have concomitant consumption of the inhibitors of the absorption, as mentioned, teas, coffees, fillets like whole grains, calcium products, or supplements, and the use of antacids or antibiotics like tetracyclines or oral quinolones within 2 hours of the iron injection also will inhibit the iron absorption. So if the patient has coexisting inflammation with functional iron deficiency, the iron absorption will also be poorer compared to those just pure isolated iron deficiency. So that is why in the patient with coexisting inflammation or functional iron deficiency, you may expect the hemoglobin level to normalize. Okay, so inadequate iron absorption can also be contributed by any intestinal mucosal disorder like celiac disease or inflammatory bowel disease. In this condition, not only iron absorption is impaired, but you can also have impaired absorption of the folate and B12 as well. And because the low pH, the acidic pH is important to for absorption of the iron. So when we use drugs like proton pump inhibitor, or when the acid gastric secretion is reduced in condition like gastric atrophy or autoimmune gastritis, this can actually impair the iron absorption orally. Similarly, when we don't have the gastric, when they have been resected or there is gastrointestinal bypass procedure, you can also have lack of iron absorption. Similarly, Helicobacter pylori colonization is also a cause of iron, poorly absorbed iron because of the chronic inflammation. And by just treating the Helicobacter pylori infection, more than majority of them will actually be able to reverse, okay, with the Helicobacter pylori eradication therapy. And of course, if the patient have ongoing iron loss or excessive the requirement is excess of the dose of being absorbed, they may not respond. So we need to consider if the patient have any underlying occurred or undiagnosed recurrent gastrointestinal blood loss due to, for example, peptic ulcer disease, malignancy, especially gastrointestinal malignancy, angiodysplasia, which is quite common in the colonic section, or there can be other small bowel lesions or even parasites. So this other recurrent blood loss, for example, and any other sites, for example, hemolysis, epistaxis, also can contribute to the inadequate response to the oral iron therapy. If there's presence of menorrhagia due to underlying uterine pathology like fibroids or uterine malignancy, or even inherited bleeding disorders that could actually cause more bleeding by menorrhagia. Okay. Hereditary hemorrhagic telangiectasia is also another cause of chronic bleeding. They can have bleeding from any sites, for example, epistaxis or any other mucosal lesions, and any other chronic urinary iron loss, especially when they have presence of underlying valvular heart disease or prostatic valve. In a patient with chronic renal failure, when they are given the erythropoietin to stimulate the red blood cell production to correct the anemia, so when they do response, there will be increase in the iron requirement. Okay, so what that could actually contributes to the poor response as well. Okay. Another important factor to consider when they have poor response is when there are some other coexisting condition interfering with the bone marrow response. So example, when they superimpose chronic illness, in any infection or inflammation or chronic kidney failure, if there is concomitant folate and B12 deficiency, they also can because folate and B12, they are important for the red cell production. So if you have deficiency and concomitant such deficiency and you only replace the iron without correcting the B12 and folate, you will not get the adequate hemoglobin correction. Okay. If there is coexisting bone marrow disease or bone marrow suppression, we will also not expecting a normalization of the hemoglobin, okay, with the oral iron therapy. And of course, if the diagnosis is misdiagnosed, for example, the patient could be actually having anemia or chronic disease or due to chronic renal failure, or there could be multiple causes of anemia in the patient. That could actually contribute to the lack of response as well. So it's not uncommon as well in a patient with hemoglobinopathy or thalassemia, they could have a concomitant iron deficiency anemia or even folate deficiency anemia. Okay, so the least common is actually the refractory iron deficiency anemia. So here it's very, very, very uncommon. So I won't be talking so deep about it. Okay. Okay. So this is just to show the few irons, intravenous iron that is available. In Malaysia and in my center, we only have IV Cosmofer and also IV Venofer available. So we don't have the others available in our country, but in some private sector they do have IV Monofer. So the benefit, as mentioned, IV iron, they can replace the iron storage much way faster than the oral iron therapy. So this is a formula as well. Here, Genzoni's formula. As for students or even doctors, we don't have to memorize it. There are actually calculators on the apps available. So it's just to have an idea that you can actually calculate how much to replace, and this will actually be dependent on the patient's body weight. So in summary, anemia is not a diagnosis, but it's a condition which is very common, encountered in any disciplines, and you need further assessments and investigations for its underlying severity as well as causes. And similarly, nutritional anemia due to iron deficiency or folate or B12 deficiency, it is not a final diagnosis. It can be due to underlying cause, for example, gastrointestinal bleeding. But the gastrointestinal bleeding, for example, will also need to be further worked up to know whether is it due to bleeding from varices, or is it due to bleeding from peptic ulcer, etc. So, or even malignancy. So, the anemia is need to be further worked up, and you don't stop at treatment. You really need to find out and explore the underlying cause to manage it optimally. Otherwise, the anemia will not be corrected. Okay, so anemia management is based on the underlying symptoms, severity, as well as its underlying cause. In severe or acute symptomatic anemia, they may need urgent referrals to depend on the underlying cause, and also for urgent management. And early referral to hematology is warranted if the anemia is involving other cell lines or hemolysis, or there can be unexplained splenomegaly or lymphadenopathy or abnormal bleeding. And also, if the anemia is not responding to therapy, we should also, or the anemia there's no underlying explainable cause, we should also refer to hematology for further workup. Okay, with that, I would like to end my slides and presentation. And I welcome any questions from the audience.
Thank you, Dr. Diana, for your brief explanations. Yes, we came to the discussion session already. We already have several questions from Hasna Nurwina Sifa. Yeah, you have raised your hand, please. Directly give your question to our guest speaker. Mention your name and your grade, please. To Hasna Nurwina Sifa. Oke, untuk co-host mungkin Hasna Nurwina Sifa cannot unmute herself. Oke, sudah bisa, Hasna?
Sudah bisa, Dokter.
Ya,
Hello,
silakan.
hello, Dr. Diana. Please allow me to ask you some questions. First of all, I would like to say thank you for the awesome material that really useful for us as future general practitioner. The first question is, I would like to ask about a person with a vegan diet, which has difficult to keep their iron levels high. Based on what I read, pairing high iron food with vitamin C consumptions will enhance the body ability to absorb more iron. As what you've said before, the iron uptake in our body is limited. Can vitamin C increasing our iron uptake and help vegan to prevent anemia, since non-heme iron is not easily absorbed? And the second question is, based on what I understand, bone marrow evaluations is an invasive procedure that needs to be done by specialists in hospital. As a future general practitioner, how do we directing the patients to do bone marrow evaluations if the patient have the criteria to do the test? I think that's as my question is clearly for you to understand.
Yes, thank you, Hasna.
Okay. Thank you for the opportunity.
Okay, for Dr. Diana, please answer the questions.
Okay. Okay. For the first question, okay. Yeah, because all right. So the basic is Okay, in a patient who are vegans, all right, if they are not anemic yet, how do we prevent anemia? If they consume good amount of high iron rich vegetables or iron fortified cereals, that would actually be a good source of iron. And vitamin C or use of a drink of fruit juice will actually help to enhance the iron absorption from their diet as well. So usually, if as long as they have good intake, they should not be iron deficient, because apart from the iron that is absorbed from the diet, we also have ions that we actually recycled from our old red blood cells. So that should be suffice. We need to balance, because we cannot have, in natural way, in a healthy non-anemic vegans, we do not want excessive iron as well, because excessive iron is also toxic for our body. So that's why our body really regulate the iron level very, very tightly. We do not want to have excessive absorption, but at the same time, we should make sure in this vegan, they do not have iron loss. If they do have iron loss, for example, due to bleeding, then we should correct the underlying cause of the bleeding. We should identify the source of the bleeding, and if there's a cause that we can rectify, we should rectify accordingly. And with the anemia, with the underlying vegans, we have no choice but to supplement with oral iron therapy, because we cannot rely on the diet alone.
Okay, is it clear, Hasna?
Thank you for the answer, Dr.
Okay.
Diana.
Yeah,
Okay.
and
the second question.
May I add on? So
Yes.
in the vegans are actually they are different from vegetarian. They don't take the byproduct of the meat, not even eggs. Okay, they are actually not just at risk of iron deficient, but when they have anemia, we should also consider whether they are having a B12 deficiency as well as folate deficiency. So it's something that the deficiency that we need to think of in a vegans. They are not uncommon to have a folate or B12 deficiency, but with the food available, especially in the modern food, whereby we have a lot of things that are fortified with folate. Folate deficiency is less common if the vegans is taking is taking orally well. Folate deficiency is very uncommon. But if they take orally well, they're strictly vegans, they may have an issue mainly with the B12 deficiency. So certain food we do encourage the vegans to take is, for example, like Marmite. Marmite is a yeast extract that is actually rich with vitamin B12. So, but that is actually useful to help to avoid being B12 deficiency. But when they develop B12 deficiency with symptoms like anemia or neuropathy, then we have no choice but to supplement it, the B12 parenterally. Okay, all right. For bone marrow evaluation, may I know, the question is, how do we counsel? Is it as a general doctor? What was the question? Huh? Do you mean how do we counsel the patients to do bone marrow, or what was the question again?
Okay, let me repeat my question.
Right.
Based on what I understand, the bone marrow evaluation needs to be done at the hospital.
Yes.
But me as a future general practitioner needs to direct our patients to do bone marrow evaluations if the patients have the criteria to doing the test. Yes. So how do we directing the patients to do the BM evaluation, since it is an invasive procedure that needs to be done by the specialist in hospital?
Okay, so bone marrow evaluation usually is a procedure done by in our Malaysia setting here. We normally, this procedure is done by a trainee in medicine, okay, or trainee in internal medicine or hematologist. So it's not done by the junior medical officers or housemanship, we call it. And to usually to counsel the patient for this procedure, we should counsel the patient what are the indications that we do this test, okay? Because it is an invasive test, so we should counsel the patient what are we suspecting. If we are example, if we are suspecting a bone marrow disorder due to leukemia or a bone marrow disorder due to underlying myelofibrosis, which is a fibrosis in the bone marrow, or any other condition, like for example, due to bone marrow infiltration, we will counsel them accordingly because these are the indications. And so once the patient understands the indication, then it will be, there will be more cooperative to let us perform the test. To perform the test, we should also explain, we should also work out, make sure there is no underlying risk of bleeding. In particular, the patient may be taking anticoagulation or antiplatelet. We would have to be more cautious if they could not stop those medication or antiplatelet, or if they have a bleeding disorder such as severe thrombocytopenia due to the marrow disease, we sometimes might need to actually support with transfusion of the platelets if indicated. Okay, so these are the things that we counsel them. What is the indication, and then make sure we prepare, we support, we do the relevant pre-workup, make sure there is no coagulopathy, make sure there is, if the anticoagulation can be withheld, we withheld it. Or if there is a severe thrombocytopenia, we can reassure the patient in case there is bleeding, we will support with the platelet transfusion. So these are generally how we counsel. And the risk of bleeding usually is not very high. Of course, there can be risk, but it's not very high because the bone marrow is done over the posterior superior iliac crest, which is rather superficial and palpable, and we can actually compress them very well. So post-procedure wise, we should compress them, advise the patient to lie prone and with a thick gauze to compress the site of bleeding for at least half an hour. And also monitor for any sign and symptom of bleeding, like any drop in blood pressure or any tachycardia after the procedure, and re-evaluate post-procedure to make sure there's no hematoma. So it should be outpatient procedure usually. So usually, as long as the patient understands the indication, and if we counsel, if we know the underlying diagnosis, we can treat early, or we can intervene early, so the patient will be more cooperative as well to do the test.
Okay, thank you, Dr. Diana, for the answers. Thank you, De Hasna. A good question for you. Okay, the next question came from Fahri Novaldi. Yeah, please, Fahri Novaldi.
Okay.
Okay.
Thank you, Doctor. Thank you, Doctor, for explaining before. My name is Fahri Novaldi, a medical professional student, Doctor. There is two questions, Doctor, I want to ask. My first question is, in iron deficiency anemia, the iron therapy can be give oral or parenteral, and the parenteral iron therapy required when we need to increase rapidly iron store. And my question is, how we know that condition, Doctor? Because we know that iron overload make the hemochromatosis condition, and or how to avoid the incidency or of iron overload, doctor. And my second question is, in Malaysia, where is citizen go to examine their disease for the first time, doctor? Is there is a clinic, primary health care, or they can directly to the hospital? Or maybe there is a screening for people or person who has a risk factor, doctor. Thank you.
Okay, so the first question was when with regards to IV iron therapy, how okay, so IV iron therapy we give. How do we want to avoid to have hemosiderosis or iron overload, isn't it? So actually we can calculate based on the formula. So we can have based on the formula, if you look back at the slides, I'm not sure I can show you the slides. You can actually have the target target hemoglobin level that you want to achieve. So that is why it is very unlikely to cause iron overload, because you will know what is the target hemoglobin that you want to achieve, so that you can calculate the dose to give accordingly. Okay, and when do we give IV iron therapy? So we give it actually when we want to get a rapid iron store correction to replete the iron storage, especially like, for example, the patient is going for elective surgery. Elective surgery can be in few weeks times, or 1 or 2 months, for example. So we will have time to correct the iron using IV iron therapy, rather than using oral, which will be very, very slow, especially if the anemia is moderately or severe. Okay, so if the iron if the iron deficiency is mild, and we can actually consider oral, because you don't need to rush. Okay, and you have time for the anemia to be corrected. But if you don't have time for the anemia to be corrected by oral, you use IV iron therapy. Okay, and for the second questions, all right. For Malaysia, both they can actually go for primary checkup. It depends on their circumstances, the condition, the severity of anemia. So most of the time they will go to the primary healthcare, or what we call in Malay, klinik kesihatan. Okay, they will normally go there, or they can go to their private general practitioner, or they can even go to lab to have a blood check, and they notice they have anemia. They will go to the clinics themselves, and they actually can go directly to hospital too if the anemic is causing them a severe symptoms. So for example, especially when there are obvious bleeding due to menorrhagia or gastrointestinal bleeding or hemolysis, the patient can actually go directly to the hospital. And in terms of screening, our country here in Malaysia, we don't routinely do screening for everybody. We don't. Okay. Although it is advisable to screen for anemia in certain population, in our country we do screening for anemia only mainly for pregnant women. They will have compulsory hemoglobin screening, and as well as other screening like virology for pregnant women. But in children or in elderly, we do not have a compulsory screening, but it is advisable in particular elderly or postmenopausal women or adult male, elderly male. We will advise them screening for anemia, especially when they come for follow-ups due to other conditions. So only then we would screen. But in general, it's mainly only for pregnant women.
Thank you for the answer, Doctor.
Thank you, Dr. Diana. Thank you very much. Anyone want to raise hand? Okay. Questions? If not, maybe we can answer from the first question, please.
Dr. Iin.
Okay. Maybe we can answer the question from. We still have time, right?
Sorry, I can't hear clearly.
Okay, let me join. Professor Diana, do you still have time?
Oh, yes, yes, I do.
Okay, thank
Yeah.
you, Dr. Iin.
Okay.
Next question.
Okay. Anyone who wants to raise hand? If not, maybe we can answer from number one, the first questions. Oh, Faisal Amin, Sikrullah. Yes, please.
Ji dokter.
Ya.
Mohon maaf dokter, suara saya terdengar mboten nggih?
Terdengar. Silakan.
Ji, assalamualaikum warahmatullahi wabarakatuh. Thank you for the time. Excuse me, Dr. Diana. I have a question. Diagnosis for hemoglobinopathy and thalassemia and etc. Are also difficult to be met in our healthcare, and can do is differential diagnosis and report to the patient to the hospital. Now, how it in Malaysia?
Okay.
Thank you,
okay, that's a very good and practical question. So, when we suspect if the patient has hemoglobinopathy or a thalassemia, importantly, number one, family history. So if the patient have a family history, the siblings or parents with thalassemia or hemoglobinopathy, so the likelihood of the patients having that is also much, much higher. Of course, we cannot rule out other concomitant iron deficiency anemia in such patients as well. It can always happen because a patient with hemoglobinopathy can also have menorrhagia if it's a female, okay? And they can also have folate deficiency because of undiagnosed chronic hemolytic anemia, and they can have folate deficiency because of high cell turnover and they were not on adequate supplementation. So that could also compound the anemia in such group. So usually what we do is we correct the nutritional deficiency. If there is a risk for nutritional deficiency, give a trial of supplements and a short trial, for example, like 2 weeks, and see the response. Because even if there is hypochromic microcytic anemia, you just have a baseline test, you don't have a hemoglobin electrophoresis, you will see if there is iron deficiency, there will be some response. Another clue, other than the family history, the full blood count, usually we would see a parameter called RBC, red blood count. Okay, how do we differentiate iron deficiency with thalassemia? That's one: family history, diet history, nutritional. Okay, and make sure there's no gastrointestinal things that can impair the cause of iron deficiencies. There's no blood source of blood loss. And from the parameter, okay, you can from the physical examination, if it's severe, if it's severe anemia with underlying thalassemia, especially thalassemia major, you may look at the features, especially like a thalassemic facies. And in iron deficiency, there may be, rarely, sometimes, there may be other features on clinical. You can see koilonychia or even angular stomatitis or chelosis, okay, or glossitis even. And when you look at the full blood count, both will actually have hypochromic microcytic anemia on the full blood count examination test. But there is also a factor that you can highly suspect thalassemia, especially when the red blood count is high, more than 5. The value of RBC count more than 5, it indicates that the production of red cell is high, okay, to compensate for the hemolysis in the thalassemia. Okay, whereas in iron deficiency anemia, okay, they are low. the red blood count is low. In addition, both are anemic. Thalassemia versus iron deficiency, both are anemic. Okay, both have low MCV and MCH. But iron deficiency anemia, the red blood count are typically low. RBC count, you will see the RBC value typically low because they lack of the building block to produce the red cell. In hemoglobinopathy or thalassemia, the building block is sufficient except for the globin chain. The globin is reduced. So you have a lot of red cell being produced, but they are not normal in terms of the lifespan, in terms of the size, because of the lack of production of the globin. It can be the alpha globin or the beta globin. So that is the difference. Okay, and of course, in thalassemia, in iron deficiency, it is a nutritional deficiency. So when that happens, the iron deficiency, it does not occur overnight. It occurs gradually over a period of time. And what happened is that when the bone marrow produces the iron deficient red cell, the cells are small. That's why the low MCV. But the small cells are not even. Some small cells, some of the red cell may be very small, some are slightly small, some a little bit small, but not too small. So in terms of the variation of the small size, is variable. They are small, but they are variable. And there may be certain population that are still normal size because the red blood cell, the lifespan in the circulation is 120 days. So if the iron deficiency just happened about 2 months ago or 3 months ago, so some of the red cell that is still alive, still survive, still has normocytic size. So we see that they, on the peripheral blood film, the size are uneven. There can be some normal, but majority are small. Okay, there can be still some normal. And that is why another parameter, when we do the full blood count testing, we see the RDW, which stands for the red cell distribution width. So you see the diameter of the red blood cell. Because of the iron deficiency, there are some are small, but some are slightly small, but not so small, and some are normal. So they have a range of small iron. Okay, so that is why the red cell distribution width is increased in the iron deficiency anemia, whereas in the thalassemia, the red cell has been small since the production in the bone marrow because of the globin chain, which is stagnant. Okay, so because of that, the red cell distribution width in the thalassemic patient, they are very even. They are very even. So this is how we suspect, even without a hemoglobin electrophoresis, we can suspect a patient having a thalassemia or an anemia. And of course, the PBF findings sometimes can be also quite helpful because in addition to the hypochromic microcytic cells that you see on the peripheral blood film in iron deficiency, you can sometimes see target cell, but that also can happen in the thalassemic cell. So if the thalassemia is very mild, it may not be that helpful, but if it is severe, then you may see more features like the increase in the variation of the size and shapes. They're very, very weird shapes as well. But pencil cells are more common in iron deficiency anemia. So you tend to see more pencil cell shape or cigar shaped cells in a PBF of an iron deficiency anemia. Okay.
Okay, thank you, Dr. Diana. We still have maybe 17 minutes to go, right? Okay, there are still 2 persons raise their hands. The third one is Regita Ardana. Please, yeah, you can ask your questions after this. Saudara Marhagio.
Okay. Thank you, Doctor. I'm so excited for your short course of current materials that's so relatable to our near future as a general practitioner. And I would like to ask you about the source of iron itself and how it would affect the people in our community. As we know, as mentioned before, in last question, iron is present in food products in two forms as heme iron and non-heme iron, which is found in both plant and animal products that differ in their chemical form, absorption process, and uptake mechanism. Heme is iron highly bioavailable rather than non-heme. So for some people with vegan diet are at higher risk of iron deficiency anemia. So how we as a future general practitioner give dietary or maybe non-dietary advice recommendation for vegans to prevent anemia, especially iron deficiency anemia, besides supplementation as mentioned before. If there's any food plan-based recommendation or something. And my second question is, we know that vegan are high risk of iron deficiency anemia, right? But is that a primary cause or there's any cause beside their dietary intake? Maybe that's all, doctor. Thank you very much.
Okay. Iron deficiency. Okay. In a patient, so in a vegans, they may be at risk if they don't take enough in their diet, as mentioned. But to be honest, how much to take, I would actually refer to the dietitian, because in terms of quantity of the vegetables, I honestly, I cannot advise. Okay. But if there is a concern or there's a risk of anemia in the vegans, I mean, you can screen for it if you suspect, especially if the patient or the person has risk of getting iron deficiency anemia, in particular whereby the requirement is increased due to pregnancy in a female, or they're menstruating. If they're heavy menses, you may need to you have no choice but to supplement them orally if they can tolerate with the iron therapy, oral iron therapy. Okay, because to get iron deficiency, they may be probably they may get iron deficiency, but not necessarily in vegans, not necessarily they may get iron deficiency anemia. So unless we check the hemoglobin level, we know that, I mean, if they are clinically pale, then we would know. But if they are actually just iron deficiency without anemia, it will not be easy to tell unless we do the iron study in such people, unless they have other symptoms due to iron deficiency without anemia, such as pica or some lethargy or hair loss, as mentioned earlier. So to educate them to prevent it is, of course, to take rich iron diet with vitamin C, and avoid those drugs that or food, those food that could actually inhibit the iron absorption from their diet, because they could only rely if they are, I mean, to prevent, they can only rely on their diet. But if they are not anemic, if they are already anemic, they should be treated, and the cause should be treated accordingly. Otherwise, it will not be able to normalize. Okay, so to prevent, we should to prevent the anemia, if there is a Helicobacter pylori, for example, chronic infection, we can treat them accordingly, correct it eradicate the H. pylori. That could actually help to reverse, because H. pylori infection actually is quite common. I'm not sure in your population setting, but in our population setting is actually a very common problem. Even by the blood test screening for the antibody, you can actually identify the patient having the H. pylori infection. Or you can do urea breath test if they already have been treated and you want to rule out a recurrent H. pylori infection. But to be honest, how much in the diet to prevent that one, I would advise to see the nutritionist or dietitian. Yeah.
Okay. Thank you, Dr. Diana. Okay. The last question for direct questions. Farhan Dio. Yeah.
Okay, thank you. My name is Farhan Dio Nuarsya. I would like to ask you about transfusion toward anemia cases. As what I have learned, transfusion has risk to get infected of other disease. If the patient didn't do the transfusion but still consume food with high iron value, is it adequate to eliminate the anemia? And how much time will needed to make hemoglobin back to normal level? Thank you.
Okay. So the question is, how much hemoglobin required to make it normal level? Or how much iron to required to make it normal level? So basically, what if you to correct the iron deficiency anemia without having blood transfusion, this we can depends on how fast you want to correct, how severe is the anemia. And of course, if the severe with cardiac compromise or hemodynamic instability, we have no choice but to transfuse just up to about 8. The hemoglobin, to keep it around 8 would be sufficient. Electrolyte imbalance, risk of infections, and risk of other transfusion reaction as well. So when we need to transfuse, example, the hemoglobin may be
check. Maybe there is a low on signal.
I think Dr. Diana has lost her signal. Yeah.
Farhan Dio is asking about blood transfusion.
Yes, sure, doctor.
I think Dr. Diana is left. Yeah. Apakah Dr. Diana masih di sini ya? Host? Apa sudah live Zoom ya?
Tidak ada, dokter. Sudah ada, dokter. Dokter Diana. Sudah ada Dokter Diana di sini.
Okay. You can continue, Dr. Diana. The same problem with me at first. I have lost my signal too. She's not ready to join.
Still unmute.
Oh, sorry.
Still mute.
Oh, okay. Can you hear me?
Yes.
Okay. Sorry. I didn't realize it was muted. Okay. So how much to transfuse? For example, if the patient comes with severe anemia due to iron deficiency and the level was 4, hemoglobin of 4 grams per liter, and the patient is very having cardiac compromise, angina pain due to that. So we transfuse, but we transfuse at most is around 7 to 8, the hemoglobin. Okay. we do not transfuse the red blood to normalize the hemoglobin level, because the iron deficiency anemia, as long as we can, as long as there is no cardiac compromise or any instability, we try to supplement it using iron therapy. Okay, and how much iron therapy, what iron therapy option depends on how fast we need to correct it, okay, and how severe the symptom is. If we want to correct fast, we use intravenous. But if the patient is stable, it can take time, we can use oral iron therapy. And oral iron therapy usually we will have to take it for a few months. But IV iron therapy, you can normalize the iron store level according to the target of hemoglobin based on the calculator. Okay.
Okay. Okay. Thank you, Dr. Diana. Our time is only 6 minutes. Okay, maybe we can stop the questions. I would like to read the question from the chat room. Yeah, maybe we can answer it together. The first question is for blood component transfusion. This is from Claudia Vindi. Can we do it at the primary care in Malaysia? I think because in Indonesia, patients should go to have the transfusion in the hospital, so they cannot transfuse in the clinic. How about in Malaysia?
Same. Our blood transfusion only in the hospital setting.
Yeah, okay, it's the same. Okay, the second question is, can patient avoid anemia only by taking vitamin B12 only without eating animal food? Yeah, we have discussed about it. Yeah, a lot about patients. Yeah, Dr. Diana have answered it. Okay, the third questions. Some patients cannot tolerate well with iron vitamin because it may constipation and bitter taste. How important is nutrition therapy? Yeah, Dr. Diana has answered it either. Kemudian Regita Putri Ardana, she has directly asked the question, right? And Dr. Diana have answered it. Farhan Dio have already answered questions. Oh, this is from Erizal. Okay, this question is, when someone has a severe anemic condition, does it always need blood transfusions? Is there no other way to take care of the conditions? Because blood transfusion itself sure have a lot of risk, and sometimes it is an emergency conditions and there is no stock of blood type. Yeah. Yeah. Please answer the questions.
Okay. So if severe anemic, okay. If we, I mean, as long as the patient is stable, we should. The severe anemia, how we treat it depends on the underlying cause. For example, if it is thalassemic, we have no choice because unless they use whatever treatment to reduce the transfusion in thalassemia, that is very advanced, which are not in the primary care setting, that involve stem cell transplants and also some of the new drugs that actually modify the pathway. So it is not yet available in the market. So it's all under clinical trials. So in like condition like severe anemia due to thalassemia major at the moment, in most conditions, in most places in Malaysia, we still rely on blood transfusion. However, if the severe anemia is due to other bone marrow disorder, like for example, myelodysplastic syndrome or multiple myeloma, we can give a trial of erythropoietin, the hormone, or even the chronic kidney disease. We can give erythropoietin hormone along with IV iron therapy. But as long as the iron level has been accessed and there are no iron overload, we can give a trial of this hormonal therapy. Okay. So in that case, we can reduce the risk of we can avoid transfusion if possible. But sometimes there are really no alternative.
Okay.
And in the patient cardiac compromise, that is emergency is if the patient is acutely bleeding. So we have no choice but to replace the blood emergency. That is the only way transfusion. So we have to refer to the tertiary where the blood is available.
Okay. Okay, thank you. There is questions about end-stage renal disease. End-stage renal disease patients are often hospitalized due to severe anemia. Many patients can only afford erythropoietin injection just one a week. This is because the limitation of the insulin in Indonesia. How about in Malaysia?
In Malaysia, also the same. Because number one is the cost.
Yes,
Erythropoietin, they are not provided free, and the patient has to pay on their own, and it's expensive. So we also have the same issue given once a week, and the same issue here as well.
Yeah. Okay.
Yeah.
Thank you. It is said that in Malaysia, anemia is found a lot in patients with malaria. Is there many patients with malaria in Malaysia?
Oh yes, it's still very common. It's endemic in here, but some of them are because they're traveling outside. They are working in other countries like Papua New Guinea or Africa or sometimes Indonesia in the logging camps. So they came back sometimes with fever, and we often found them to have malaria. But anemia is just a subset of the severe malaria. Okay, so it depends on the severity of the malaria. So it's not in every patient with malaria, but if they have a severe anemia, it actually reflects severe malaria.
Thank you. There are also questions about breastfeeding mother. The babies who drink breast milk from their mother, who have history like to drink coffee. Is there any deficiency and anemia in mother drinking coffee? So the baby is also a lack of iron.
Oh, okay. I'm not sure if the caffeine passed through the breast milk, but if the caffeine does pass through the breast milk, then there's possibility that they can have a reduced absorption of the iron in the milk.
Iron, yes.
Yeah, but I am not sure about the coffee, whether it can pass through breast milk.
Okay.
Yeah,
Maybe
sorry, I couldn't.
Okay, thank you. The last questions. I wonder if it is possible for someone who always donate the blood regularly. How about the hemoglobin recovery period for this person who is always donate the blood regularly?
All right. Okay. In the first place, eligible to become a blood donor, the hemoglobin must be normal. Okay. So assume that the normal hemoglobin for a donor, a person is, for example, 13. Okay, 13. So to donate 1 pint of blood, is equivalent to 1 gram.
Okay.
Of hemoglobin per liter. So if you lost 1 pint of blood, or you donate 1 pint, it's equivalent to 1 gram. So if a patient just donate 1 pint, which is about 300 or 350 mils of blood, that is we are going to expect just a drop by 1 gram only.
Okay.
So it's not much.
Okay.
So if and the blood donation, they can only be donating every 3 months. So by 3 months, because the red blood cell will be already replaced.
Okay.
So then they will not be expected to be to be anemic if they are, as long as the person who is donating blood has no other source of blood loss.
Okay.
Okay, if they are healthy, they're very well, and they take good diet, they're not expected to have blood loss. But if they may be at risk of iron deficiency without anemia.
Yeah.
Yeah. And so that is why we encourage the blood donors to take iron-rich food to supplements.
After they donate their blood. Okay.
Yes, correct.
Thank you, Dr. Diana. I think I'm afraid this is the end of our sessions. There are still many things we want to talk about, but hopefully we can talk about it in the future. Thank you again to our guest speaker, hopefully we can meet again soon. We will also expecting our next collaboration with Family of Medicine and Health Science University Malaysia of Sarawak. Okay, good day all. Saya kembalikan kepada Dr. Rafika. Thank you again, Dr. Diana.
Okay, thank you, Dr. Diana. Thank you, Dr. Iin. Lecturer and students, that's all for today. Thank you, Dr. Diana. Thank you, Dr. Iin. Thank you all for making time to join us. We hope that we hope that all of you get advantages from this event. We look forward to seeing you at the next event. The last but not the least, let me close the visiting professor with doa kafaratul majlis. Subhanakallahumma wa bihamdika asyhadu alla ilaha illa anta. Wassalamualaikum warahmatullahi wabarakatuh. Thank you, Doctor.
Welcome. Thank you.
Thank you, Dr. Diana.
Welcome.
Thank you, Dr. Iin.